worthy faculty, residents, friends. I have the proud privilege of introducing our speaker for the day, Dr. Sanjeev Bhoi, who is currently the head of the WHO Collaborating Center for Emergency and Trauma in the Southeast Asia region. He's also the director of International Council of Critical Emergency Sonography and the Michael Moles Fellow and a professor in the Department of Emergency Medicine, All India Institute of Medical Sciences, New Delhi. Dr. Bhoi has a very long CV, and it would not be possible to read all of it out, but I would like to say that he has been a great proponent of point-of-care ultrasound, and he has created the AIIMS Ultrasound Trauma Support course. He's also created the AIIMS Disaster Ultrasound, AIIMS Emergency Sonography course, and the Acute Care Sonography course for nurses. He has created the AIIMS Disaster Ultrasound program and has been training doctors, nurses, and paramedics nationally and also for UN missions. These courses are run across the country as well as in Nepal, Sri Lanka, and Iran. Also, first world countries like the UK and the USA. He's the program director of International Council of Critical Care Sonography. Dr. Bhoi has started the AIIMS Community Emergency Care Initiative since December 2009, and his team has trained 5,000 medical and non-medical personnel, including defense and paramilitary forces, on basic emergency care since 2009 across 15 states in the country. Dr. Bhoi has authored CPR chapter for School Curriculum of India from 7th standard. He has started the PhD program in emergency medicine at the AIIMS Trauma Center, and his area of interest is translational research and shock. He has published widely in emergency medicine on the use of emergency ultrasound and translational research in shock. He volunteers in the poorer and more vulnerable states of Northeast India, of Arunachal Pradesh, Mizoram, Manipur, and Assam, and teaches community emergency care in basic trauma support and CPR. A very affable, approachable person who has taught all of us a lot, and we all love him for what he's contributed to our upbringing. Thank you so much. And Dr. Bhoi, please deliver it.
Good morning, and thank you, Dr. Naveen, for such kind words. So we just did a little bit what my passion is, and I also thank the host, AIIMS Jodhpur, and I also thank the director, Professor Mishra, and the other dignitaries who are present in this talk. So I give a warm welcome and also greetings from All India Institute of Medical Sciences, Delhi. So, and I look forward to this talk with a great pride, because this is the time when everybody is in as a community, right from students, or from the junior-most student to the senior-most student, and the faculty members, and everybody is around here. So when I was actually told by Dr. Ramkaran that you need to speak on point-of-care ultrasound, it's your passion, and I took it very nicely. And today I am going to talk about two different paradigms of using point-of-care ultrasound during your resuscitation, as well as how you can bring it right from when you are young minds in the undergraduate medical education, which is quite innovative. So let me take you to the journey of resuscitation. We all know that emergencies can occur anytime, any place. No time, any place is immune to an emergency. It can happen right inside in the podium here. So it happened to President Kalam when he was actually lecturing and collapsed, and he did not even get a CPR. So we have that paradigm, and we are going to talk about point-of-care ultrasound being used in resuscitation. So you see there are two different aspects of resuscitation. So we know that we are here for a trauma symposium. I'll just take you a sick patient coming to the emergency room, and how actually, as I said, there are two different paradigms of resuscitation. Today we are going to talk about the highest paradigm of resuscitation, that is use of a new skill. So it is early morning hours in the emergency room when I receive a patient, who is actually had a road traffic crash, and he is hypotensive, tachycardic, tachypneic, cold, clammy, and confused. So what do? You are a sick patient, trauma, not trauma. You have to take care of the patient with a concept of treat first, that kills first. And we know the bread and butter of any acute care physicians is the ABCs. You stabilize the primary survey, save him, use your adjuncts, both your knowledge and the skill in the right time, and then take care of the anatomical defect. But for doing that, you need to have a protocol in place. Protocol entry, and it has to be done in quick time. You cannot wait for that. Quick time. Just like you must have seen the Formula race, car race 1, how they change the tires. They just come and the tires are changed and the car zooms. Without talking to each other, they just change the tires in 10 seconds. So resuscitation is similar ball game. So it is the orchestra of resuscitation has to be done in a quick fashion without speaking to each other, and it is time critical. And that's why you use all your skills. As I said, you have to have airway skills, you should know to do chest tubes, you need to, giving the right kind of, if you require a CPR, you need to do. So you require all critical intervention in short time. And when you're doing in such a complex situation, both situational is so complex, high intensity, high adrenaline is pumping, you are bound to, land up in errors. And we know while doing an 8-hour shift in the emergency department, you do actually 50 errors in 8 hours. That is the statistics says. And some errors which can lead to fatality, some errors may be a near miss. Oh my God, I just missed it, but the patient is saved. Or you do no harm, but you do increase the morbidity of the patient. So errors. So to reduce error, you need to be more visual. The technology which is there. So it is not reinventing the technology, but re-looking the technology. Using it from the diagnostic paradigm of a closed environment, control environment, to radiology, to uncontrolled environment in the resuscitation area. And that is the game changer. So now, what I am talking about is the point of care ultrasound. The ultrasound being used in resuscitation, saying that it is a resuscitative ultrasound. So let's see how it looks. Is highly goal directed. You are asking a focused question. If the patient is in shock, you are asking in a trauma patient, where is the bleeder? Where the patient is bleeding from? Is he bleeding from the chest? Is he bleeding from the abdomen? Or is there blood around the heart? So you are asking a critical question and you want a quick answer, yes or no. So if the patient has a a tamponade, immediately what he'll do, the next step is you to relieve him. Put a needle, save him, otherwise he'll go into arrest. Or if there is a blood in the tummy, call the surgeon immediately, shift him to the OR. So it empowers your decision-making skills. And what is required, it is required all the time in the bedside. It is critically time dependent. Because it may be too late by the time you call the experts, it may be too late. If the patient is in shock, almost in peri-arrest, by the time you call the expertise, it may be too late. So that's why there are various kinds of ultrasound you can do on the bedside. So there is a whole algorithm of this. So we talk, and for that you need to have a proficiency. You should be proficient enough. But remember, this is the learning curve is fast. You should be trained, yes, you should be adequately trained, and you should be proficient. And proficiency can only occur if you practice, practice, and practice in the situation. And number is not a problem in our country. So that's why when we started, actually, I'm a I'm an emergency medicine fellow. Actually, I am a medicine guy. I joined emergency medicine. My passion is to develop emergency medicine in our country, and that's why we traverse the journey. And while doing that, I learned the skills myself. And when we're going to start point of care ultrasound, there are a lot of inertia because it has been the radiologist's domain and still it is. But what happened was, when you see echo was picked up by the cardiologist, nerve blocks picked up by the anesthetist, so everybody started using in their field, if you see. So when actually it comes to resuscitation, why not in the acute care setting? So to convince our people, we did a study to pick up fluid in the tummy during initial resuscitation in trauma between the radiologist and the non-radiologist community, and we proved a point that the AIIMS study was equal, or if not better, to the international study where they compared non-radiologists versus the radiologists in picking up fluid in fast scan. So that means we proved a point that yes, you can do it. It gave an armamentarium, or it got strength to the non-radiologist to perform point of care ultrasound on the bedside. So what we did is, yes, we can do, but how to do it, what algorithm we should profess. So what we did is, like you do ABCDE in any acute care setting, it is index case of trauma. So actually when you manage trauma, you use ABCDE way. And as I said, from the blind to visual resuscitation can we traverse a journey. So what we did is, by doing it, practicing every day in, day out, round the clock, we build on stories. From the stories of the patient, when we manage and use ultrasound, we build it up as ABCDE algorithm by ultrasound. But why ultrasound? As we said, it is a visual stethoscope of the 21st century. From Laennec from sound, you see, Laennec invented stethoscope, and the sound you decipher and make out whether it is mitral stenosis. Similarly, this is the sound which you can see, and that is the visual stethoscope, and with the concept of treat first that kills first. So let's see what we can pick up while you are doing airway, breathing, circulation in trauma resuscitation. And you see that in airway you can pick up airway injuries. It is not possible clinically. You can pick up threatened airways, because if there is a paratracheal hematoma, you need to intubate them early. We had patients like that. There was a girl who came, there was a chunni neck stuck in his neck. Suddenly patient comes to the emergency room in the triage bay and saying, "Doctor sir," so while narrating the story, she collapsed. And we took him to the red resuscitation bay, and we did a scan. We found paratracheal hematoma, tubed him early, called anesthetist because they're difficult intubation, and you can guide the procedures like doing a surgical airway. Needle crick or a surgical cricothyrotomy, you can guide them. You can find out while doing this thing, you can do a peritracheostomy evaluation. We know there is fatal hemorrhage which can occur if you have a midline vessel crossing in the midline of the neck, and you give a stab, it can cause torrential hemorrhage and death of the patient. By doing a simple ultrasound scan, which takes no time, you can find an abnormal vessel and you can avoid that. After you stabilize the airway, the major killer in breathing in trauma resuscitation is pneumothorax. And we know you can pick up, see, earlier days, air was a villain for ultrasound. But you see the science keeps on changing, it has changed full circle, and Daniel Lichtenstein paper, which changed the game. And you saw that tension pneumothorax, you can easily pick up by pneumothorax, hemothorax, lung contusions, pulmonary edema, pneumonias. This all which cause respiratory distress can be easily, you can have an algorithm called as blue protocol to differentiate between the critically time dependent differentials of acute respiratory distress, and you can use it by ultrasonography. Studies have shown beyond doubt that when you compared against the CT scan, the diagnostic accuracy of point of care ultrasound was better. then clinical exam and chest X-ray. However, clinical exam is our cornerstone. The message should not go wrong. So after you do AB, stabilization of airway and breathing, then you come to circulation. Circulation, we know that in shock, undifferentiated shock, in trauma, we know that unless proven otherwise, it is hemorrhagic, hemorrhagic, and hemorrhagic. However, there are other causes of shock and trauma. Just like you can pick up tamponade, tension pneumothorax, or tension physiology causing a shock in trauma. And you can quickly differentiate by using a point of care ultrasound and do a goal directed echo. You can pick up the bleeder by doing a fast scan. You can pick up even fractures causing shock. Obviously, the clinical fracture will be obvious. Swelling of the thigh, you can confirm by doing a quick ultrasound and pick up fractures. So this is how you stabilize the airway, breathing, and circulation. And you can traverse the journey from blind to visual resuscitation. So after you stabilize the patient a little bit ABCs, you can still find out. Some of the patients we know that the patient will be in shock and patient also has a head injury. You cannot shift them for CT scan, because we know that the death begins in the corridors of instability, because the unstable patient, if he goes out of the emergency, there is a chance of mishaps which can occur. So that's why, suppose the patient is going straight away to the operation theater, you should know what is there in the upper story. And that is for doing that, you can find out either a raised ICP. You can find out by doing a cranial ultrasound. You can pick up doing a optic nerve sheath diameter. That is a D part, disability. And trauma resuscitation does not mean fracture. It means that you have to find out the neurological deficit. So you can say that optic nerve sheath diameter you can pick up. You can pick up midline shift. You can do a pediatric cranial ultrasound by the anterior fontanelle. We have picked up EDH. And you see, you can do guided procedures, because that addresses the patient safety. We have seen mishaps happening while putting a central line. So this standard of care now is to use ultrasound for all the procedure, whether you do thoracocentesis, paracentesis, central lines, blocks, intraosseous, you can guide it by ultrasound. And we have devised an algorithm called as dynamic intubation, which paper is out. So you can guide intubation by ultrasonography in all the 3 phases of rapid sequence intubation. You can adjunct it actually when the patient actually arrests. Same patient, if it goes into arrest. We talked about the patient, he was hypotensive, tachycardic, tachypneic, you are doing ABCs, you are adjuncted clinical with the ultrasonography, you are address the issues, but suppose the patient collapses. You can do code blue ultrasound guide, and we have been doing since last 7 years. We have published a paper, what is called the AIIMS CLIP protocol. Comes with the AIIMS name, cardiac, lung, and IVC protocol. And it makes sense to use it. You can relieve, if the tamponade coming with cardiac arrest, no amount of CPR is going to work unless you relieve the tamponade. No amount of CPR will be enough if you don't relieve the tension pneumothorax, So these are the critical time-dependent things which you can do. And in non-trauma, you can pick up a pulmonary embolism causing an arrest. So that you can pick up by ultrasound. Regional wall motion abnormality. So you have to activate the cath lab by simultaneously doing a goal-directed echo. So these are the paradigms. You see how it can be traversed and how it is beautifully can improve the situation and reducing the errors, high yield outcomes you can achieve by ultrasonography. So how to do it? You can see this is situation in the emergency. You can do it can be done also by a paramedic en route in the ambulance. It can be done in the field. So because we know that the handheld ultrasound has come, and we can, because of portability, you can do it in the bedside. We are not seeing it in the narrow prisms of our law. we are talking about the science. You can do pre-hospital, en route in the hospital, in the emergency, in the definitive care, in the OT, in the wards. So remember, this is the thing. And who can do it? The person who is trained in the West, but the medic does it. In the West, they do, nurses have been doing many procedures. So how it has panned out in our country? In our country, we have now disseminated to all residency program in emergency medicine. 30 medical colleges and 100 hospitals has got academic program in emergency medicine. We have got it notified by the Medical Council of India. We have sent it, and the Medical Council of India says that all clinical branches of medicine, like pediatrics, medicine, anesthesia, all clinical specialty, should actually get trained in point of care ultrasound. All the procedures should be done by guided procedure to reduce medical error for quality improvement. So this is a notification we got. Third, we have ingrained at now AIIMS Delhi, all the mandate was when Professor Mishra was there. So now it is there for all residents to get trained. So there is a training going on. Third, we have brought it down to nurses who are working with us in the trauma resuscitation bay. We have trained all our nurses the same algorithm what I talked about to the nurses. Especially in mass casualty situations, they do pick up fractures. You know that in mass casualty, there are a lot of injuries, and every patient is a medical legal. You can't do X-rays in every patient. But if you do a screening musculoskeletal ultrasound, if there is a cortical break, that patient goes to the X-ray written by the doctor. But screening ultrasound, you can do that. Bring it to triage, sonotriage, musculoskeletal ultrasound, being done by the nurses. So these are some of the concepts, empowering or doing task shifting to the people, because you are there for high expertise, doctors. You can't now do that, I will do everything. We cannot do everything. We have to make a team. And that's why it is a concept. Across the board, we have kept it. Doctors, nurses, as I said, Dr. Naveen was telling about the UN mission. What we did in UN mission, we trained the paramedics. We trained the NDRF people. They are on the floor. We know that in our country, NDRF acts in all calamities. So we have trained them in how to pick up pneumothorax, how to pick up fractures, which is critical during disasters. So now, if you see, this part of my talk was about how a resuscitation can play a part and how it can be ingrained into the, if you see, into the different parts, different people, doing it. So when you are doing this, this is a cultural thing. Now already we are late, the world is moving fast. So how actually we learned reading a chest X-ray. If you see, so how actually we learned chest X-ray? Chest X-ray we learned because when we were posted into the 4th semester, when we went to a bedside clinic, our professors kept on teaching about, how to read an X-ray. And I'm sure that all physicians, all medical doctors can actually read a chest X-ray irrespective of the specialty, because we were induced young. The young mind captured it. That time there was no much technology, but one technology was there to read a chest X-ray, and still holds true. Even we talk about PET, SPECT, but still the basics is a chest X-ray. Everybody knows it. What is something abnormal? Okay, so this is how we did it. Now when we're talking about the technology of the 21st century and bringing it down, how we can ingrain in our young mind, that is the key question. And this is what we did it in 2011. a World Congress, and actually I was taught by my mentor, University of South Carolina, Professor Richard Hoffman, who works on undergraduate medical education. How we can integrate and why ultrasound need to be integrated in undergraduate medical education. And we have done some work last 5 years in AIIMS Delhi as well. So we know that nowadays, if you see, nobody wants to attend a lecture, so I am now standing and giving you a lecture. Some of you will be very interested, so it is my job to make you getting interested in my lecture. That is my job as a person who is delivering the lecture on the floor. Sometimes when we actually go to the classrooms, so what happens is, when you go and it becomes like this, people are not interested. They can read many things are available in the web. Information is huge information. And if you see lack of micro teaching, makes you sleep as well. So this was a famous article. This actually took it from an article if you read in any jam, So the concept of a classroom teaching. So there was an editorial, you can read, it's a brilliant editorial. In any jam it came, saying goodbye to lectures in medical school. Can it happen? This is what is called as the flipped class concept. Flipped class concept. So what people do is give the audio visuals, less than 15 minutes. So suppose there is a lecture, give the audio visual of the students, share it with the web, share with the e-platform. Because now the boys are tech savvy, they can read everything in the mobile. They read or see in the video, audio visual, not more than 10-15 minutes, and they come to the lecture. And then you engage them in discussion. That means in a more interactive form is critical. But why ultrasound need to be actually ingrained? As I said, we just now heard how beautifully it can save lives. And all about medical school is saving lives. So it does help in saving lives, taking quick decisions in no time. So it is a great teaching modality for teaching as well. And we know that in medical education, when in undergraduate, many things we need to mug it up. So we have to devise new multi-model educational platform. Not only classroom teaching, multi-model. You can bring simulation technology, you can bring animations, 3D anatomies. So let's see. It is a safe diagnostic modality. Because of its clinical value, it is now the top-notch imaging modality in the world because it is in the bedside and its applicability. And we know that these machines are coming like smartphones. They have become smaller, they have become cheaper, and they are more portable, just like your mobile. So this is the handheld machine. I have no conflict of interest showing this machine. And you see the handheld machines are coming. I saw one of them in your institute. Yesterday, one of your residents was showing. This is a V-scan. Very nicely it showed me in the emergency department. And this is what actually happened. You see this slide. I am sure those who are of my age, they will be knowing what I am talking about. Isn't it, Dr. Naveen? You say every Sunday used to come. Isn't it, Professor Mishra? I must have seen this as well. So how they used to diagnose, See, this is Captain Spock and Dr. McCoy. And they should do, and they used to say, diagnose, oh, you are suffering from this. Those days we used to think, oh, this is something we can't imagine. This is just a play, just a story which is shown in the television. Imaginary, false. But that false has become true now. You see this? And that's why you can still use a small mobile. You don't have to buy even ultrasound machine. You just, in your smartphone, you just attach the probe and you have an app and you can run the picture. You just see, it's the same probe. And the probe is $500. So this is something exciting. This will excite our undergraduate students. And that's why you see that how to integrate into the curriculum. We have integrated at AIIMS Delhi, in anatomy. So we're mentoring Professor Roy. So what can you do? So there are various models like didactic classroom lectures to web-based learning to scheduled hands-on laboratory sessions. We have hands-on. sessions like thyroid anatomy we teach, cardiac anatomy we teach, and then the students, they go for dissection. So we have, these are the various models of education available in a structured way how to integrate ultrasound curriculum. I just give you a brief snapshot in this because it is a lengthy lecture, but for brevity of time, brief snapshots in first year, what you can do in first year, second year, third year, and fourth year. Who can teach, how a curriculum can be planned, in how to enthuse energy among those our basic science, basic disciplines of anatomy, physiology, pathology, then when they go to clinics. So this is what I was talking about, from flipped class to an interactive class like this. This is a flipped class model. So the students are given, e-learning platform. This, your lectures and images, videos are shared with, and then they come and have a discussion. See that? This is more now hands-on. Second form is hands-on directly. And they scan and they understand the anatomy and relationship between, say, a vessel, say the aorta and IVC. When you actually go and dissect, it is all alien for us because dead body, the appearance is same. So you are trying to teach them by using ultrasound live anatomy. Look at the live anatomy, then they go and dissect and teach them. This is how video looks like that. Okay, this is aorta with superior mesenteric artery, and you can see the liver as well. But when you are starting from first year, how to start the program? Have a discussion with your head, your university head, the dean, and then talk to the anatomist. Somebody who is trained in ultrasound, the radiology department, or who are like in our institute, we have took initiatives, and that's why they call us, and went and convinced Professor Roy, anatomy department head, and he was quite enthusiastic because he saw a new opportunity of multimodal education and he wanted to ingrain that. But he told me, you do it everything. So I told, I will do everything for you. Just give me a platform. Then how to integrate? You can use the 3D models, 3D anatomy. So this is zygotebody.com. You can see the zygote body, and you see the 3D anatomy, then do the live anatomy here, by looking at the live anatomy. This is available with a cost, zygotebody.com. There are many free atlases available. We use this one. So what we did, this is a paper actually from Richard Hoffman, where he had a wealth of experience and he did a study. How the students are taking it up. Are we overloading with more information? Because already there is a overloaded curriculum. So are we easing it out or are we using more? So when he saw the practical approach, he felt, we did a study, the ability to individually ability to scan a standardized patient, they are able to evaluate it by a third observer, by how comfortable they are. And each student was given 15 minutes to capture the image, to identify the structure and save the image and show to the guide. And they scanned right from kidney to jugulars to carotids, to the heart. So they looked at heart, kidney, liver, major organs. These are some of the pictures they showed. You can see this liver and spleen. Similarly, the jugulars, the carotid, easy to identify. And what they found out in the OSCE rating, you see this, they took 50 points at the OSCE, and the mean score of the class was 49.1. Their range was between 39 to 40, so it's quite high. And the student with a perfect score was 78%. So you see the learning curve, it was quick, pretty quick. So how you can teach that? You can teach in live models, you can teach them in cadavers, design cadavers, like a Thiel's method. Though it will, after the cadaver will be very soft if you use the Thiel's method, just like it is a live normal human being. The Thiel's method, which will preserve the anatomy. So you can flex the thing by Thiel's method. We do it. Dr. Lalwani actually learned it from Dundee, and that was the best center for learning Thiel's method. So he came, and now he is providing cadavers for us. And that is why you see that from the anatomist to this kind of anatomy. So integration helps in understanding more. Oh my God, relations, anterior, posterior, superior, inferior, where the vessel is going traversing like this, After 2 millimeters, it is traversing anterior, then it is after 3 millimeters, it is going posterior. My God, you get confused. But if you see like this, you will be better informed. So that is what, and you can go to the next is important aspect to the first year is the physiology. Many a times we mug the Vigor cycle. Systole, diastole, you see, my God, it is difficult to understand. But now when we were studying, difficult to mug up in the textbooks. Now YouTubes are available, it is showing things, but a structured curriculum, so you can talk about hemodynamics. So let's see some of the things, a heart which is beating, you can see the systole, there is a left ventricle, right ventricle. So you can explain the systole and diastole in a very nice and coordinated manner. You see, this is a carotid. We can speak about the carotid IJV. You can talk about principles like Valsalva. What happens in inspiration? What happens in expiration? Does it collapse? What happens? What is the dynamics going on with the heart? Better explained by understanding a live is showing you the visuals. This is some of the pictures. I will not go into detail of this. You can see the inferior vena cava. This is inferior vena cava draining to the heart. This is the liver. If I show to a first year, he will be excited. And you can imagine better. And similarly, the Vigor's diagram and correlate with the ECG phenomena. So it will be ECG and then which is the depolarization, and it is actually, if you see, how it is making to the cardiac cycle. What part of the cardiac cycle is on. You can relate very nicely the electrical rhythm, the mechanical aspect, the pumps. You can do that. Second year, when he goes to second year, after first year is over, second year when he goes, you can teach them the physical diagnosis. You go to clinics. Physically, can adjunct as a physical diagnosis. Okay, you can adjunct them to learn pathology and pathophysiology. Like talking about the cardiac, abdomen, vascular, neck, and pelvic ultrasonography. So as I said, these are some of the pictures where you say liver, you can see, you can measure the things, aorta, IVC, spine, the live pictures. You can understand the jugular venous, pressure at the sternal angle. We do measure clinically. But to understand better, sometimes it becomes very difficult for us to understand, to measure. It is the ingrained thing. It has to be learned. But it can become more easy if you can use ultrasound. Simple ultrasound will tell you, see that slightly angulated, you can beautifully pick up the jugular venous pressure. Or you can learn about thyroid. You see the right lobe, left lobe, and trachea. How the vessels are relations, carotid. You see, what is the relation of vessels with the thyroid? And learning about pathology is in a small group. You can teach pathology teaching sessions, clinical cases are presented, including the history, physical exam, lab data, and ultrasound finding. Everything is given. The learning is better. Then the gross anatomy and microscopic views are also presented with the ultrasound image. See, I will give you an example. You see this? This is a gallbladder. This is a liver. You see the gallstone. And see the pathology. So you will have pathological specimen there in our labs. See that? The correlation, how it happens. You have the clinical history, histopath, and then you show the stone in the ultrasound. See, the understanding is better. You see, different things. Clinical exam, you show them clinical exam, then you have pathology, and you look histopathology and the stone. Then problem-based learning, it is very important in our formative years of learning as a doctor, for becoming a doctor, is problem-based learning. See, now people have graduated into this. A patient comes, young patient comes with dyspnea. And we know young dyspnea, there are various differentials. So when they come with dyspnea, we try to examine the patient. Patient has got bilateral crepitations and wheezing. This is a clinical finding. It is DVP raised, and he has a basal crepitation plus he has got a, you see systolic and diastolic murmurs. So it is getting confused. Is it a systolic murmur, diastolic murmur? Oh, I am hearing S3. See this? But when you show them the ultrasound, ultrasound will tell you, oh, this is a patient with a wet lung. Confirmed wet lung by ultrasound. Wet lung means pulmonary edema. Or patient has a heart problem, like patient has a mitral stenosis. See this? Mitral stenosis, opening is difficult. Left atria is enlarged, back pressure changes. And then back pressure changes, atria enlarged, the lung will be congested, like chronic venous congestion of the lung. See how you can actually learn or solve the problems with understand the pathophysiology in a brilliant way in the clinic. So how you can learn that? Many things. You can learn on live models in the clinics with the help of your teachers. You can learn that. Stable patients in the OPDs, you can learn that. You can use phantoms, task trainers, This is a virtual table, anatomy table, where it is coming. So you can get phantom like a vessel. Or you can use smaller pocket size ultrasound, and understand. So this pocket size ultrasound gives this image. So it is as good as any good one. In the 4th year, when actually is becoming final year, this is the time actually when you have to have a posting in the casualty of the doctor. Generally in the casualty, when we have posting, we take it as a posting to run away to canteens, isn't it? So casualty posting means, aram karte hain. I did during my UGs. Most of it. Things are changing. As I showed you, this is the dynamic department. You can't predict a condition. You cannot predict how a patient will behave, what procedures are required. So it is a high-stake environment. And for that, training basically them that it is a high-stake environment, it requires critical skills, making it one of the emergent situations, making a point that you need to integrate all your skills and save lives before you come out of the final year student, you integrate this and post them in the casualty. They learn, have a radiology posting. While doing the radiology posting, again they will have a feeder from ultrasound. You can have a small capsule course like we are going to do today. We have a capsule course today, the AUTLS course. You can put them on that and have an interdependent learning. Interdependent means a 4th year, a final year can teach his own 1st year guys. Or you can build on, like we are going to start. When we started, we're going to train now the anatomist, the physiology people in understanding the basics of ultrasound. So they can, once we teach them, they will graduate basic anatomy or sonophysiology they can learn, and they can keep on training their students, or the final year students can have an interactive and train their own younger colleagues. During resuscitation, as I said, you can do that. In this you can do in the simulators, and there should be a portal for reviewing all these images for them. And you can take a basic assessment, feedback from your own students to improve the curriculum, on various domains of sonography. So this is the simulators. We do have a simulator at Delhi, and this is what we did with anatomy 4 or 5 years back with Professor Roy. I was teaching first with the thyroid anatomy. So you can see all our 1st years sitting there, and we had a short didactic lecture of 15 minutes, just quickly told what are the probes, what is the gain, simple things, which button to touch, which not to touch, and then I explained a little bit about the thyroid anatomy. And then you see, we didn't have volunteers. We didn't have any volunteers. So the volunteer was the student himself. So they kept on, they practiced on each of them. They volunteered on each other. And it was very exciting for them. You see this? And after that, they went to dissection. Similarly, we are done for cardiac anatomy, cardiac cycle, we trained them, that they went for, after that, dissection. Very recently, so now it has been ingrained in the first year curriculum, especially in sonoanatomy. We had a discussion with sonophysiology. The department is quite excited to take it ahead and bring it to the sonophysiology to understand better physiology. So in my concluding remarks, you saw that we talked about the resuscitation aspect. Already now we are adult learning, and how we can make a difference in resuscitation. So if we ingrain that habit when we are young, when we are in the formative years, you see that we will be providing a guy, medical professional, to our community who will be actually skilled or empowered to reduce errors and address patient safety and making a big difference. So ultrasound has potential to fundamentally change how we teach and practice medicine for the benefit of both patients and learners. We must ensure ultrasound education and clinical practice are coordinated. It is not a replacement. Clinical medicine, the best bedside clinical teaching is the best. This is the adjunct to that. And it should be held in high standards in our profession. Our approach must be multidisciplinary, patient-centered, critically assessed, and competency-based. Thank you very much for your attention. Any questions I'd like to take?
So 9 years back when we learned ultrasound fast under you in trauma center, and then I went to join endocrinology program. The first thing which should come to my mind is to, whenever I see goiter, is to do by, you take up a probe and see what it is. But there occurs some kind of, do you think there's need for some kind of de-learning on part of clinicians? Because I went there, I would, there was an ultrasound machine and I would try to, I would do the first thing is to ultrasound, but they would tell, first palpate whether it's goiter or not, whether moving with deglutition or not. Do you think some kind of de-learning is needed?
You are absolutely right. So in adult learning, you have to, de-learn and relearn things. So we have to actually clear our slate. Slate means mental slate. Some of the things we are pre-notions. When I started using, say, I used to get scared of ultrasound in my post-graduation days. Everything looks black and white, So you get scared because if you don't have knowledge, naturally you get scared. So actually when I saw it is very exciting and saving lives, viewed in that aspect, so I had to unlearn my notions. And then you fresh slate, then I relearn things. You're right in saying that. But if you see and come and observe how to get enthused, go to the acute care setting and see how it is actually making a difference. This is just a lecture which can give you some points, but go and see and then you believe it. That makes a difference. But good point. Thank you.
So, wonderful talk as usual, and very, very illuminating as well as inspiring to be able to do this. The only thing is that we need to, as you rightly said, wipe the plate clean, be receptive to new ideas, and be willing to try out new things and not be afraid of failing. Yeah. I think the fear of failure, how I would look when I am not able to perform as well as the other person, these are fears that are in our hearts and they prevent us from going further and trying to learn new things. And at some point of time in our lives, we all enter into that nice cocoon, that comfort zone of ours, and we are very, very reluctant to try out new things and then be seen as failing in the eyes of our peers and in the eyes of our students. I think that's what we need to get rid of very quickly and be willing to learn, fail small, learn again, learn something better, and then finally succeed. I think that is what we all need to maybe work on. And there's no denying, nobody can stop an idea whose time has come. And I think ultrasound is actually an extension of the hands of a surgeon. Just like a physician uses a stethoscope, we all should be able to use an ultrasound machine. In the West, the residency programs are not certified until you have an exposure to ultrasound. I'm sure in time we will also get there. We'll need to be open-minded about it. But thank you very much for a very inspiring talk.
Thank you. So as you said, failing, don't be afraid of failing. Actually, when I was starting new, I failed to pick up spleen, for 1 month. I kept on doing in front of my students only. So very good point by you, and very well taken. Thank you very much again for giving me opportunity to speak in front of such an august audience here. And thank you very much. And we're open to doing more and more here. Thank you.
I request Dr. Kuldeep to come on the dais and present Dr. Bhoi with a small memento of our love and appreciation.